So today I wanted to speak about cellular therapies and stem cell transplant in tumor. Now, I don't have any conflict of interest with respect to this presentation. Now, the flow of the presentation would be we will discuss the basics of CAR-T. We discuss its application in neurological tumors. We discuss the basis of stem cell transplants and applications in germ cell. And let's look at the basis of CAR-T. For those who are uninitiated, CAR-T stands for chimeric antigen receptor therapy. Antigen receptor therapy. And how it is exactly done? You actually collect blood from the patient, and this blood undergoes a process called leukapheresis. From this leukapheresis, you actually try to collect the T cells. The T cells are taken in the lab. In the lab, these T cells are inserted with a vector. This vector, along with it, carries a chimeric antigen receptor manufacturing unit which targets a tumor associated antigen. So in CAR-T, you will see the word TAA, tumor associated antigen, which would be commonly described. So the vector, along with the chimeric antigen receptor manufacturing unit, or the TAA, will transduced inside the T cells, will get integrated with the DNA, and it would enable the T cells to make these CARs. Now, these CARs, when administered in the body, would react with the tumor and lead to tumor lysis. And that's the basic principle of CAR-T. Now, CAR-T, today we have 5 generations. The structure of any CAR-T has an extracellular domain, a transmembrane domain, and an intracellular domain. Now, for the students, the extracellular domain and the transmembrane domain doesn't change with the generation of the CAR-T. What changes are the intracellular domain. What is the extracellular domain which is made up? The SPFW stands for short chain variable fragments, which is a conglomeration of an immunoglobulin heavy chain and a light chain with a linker. This is actually the part which identifies the tumor antigen. Now it's attached to a linker. The linker is attached to a transmembrane domain and to an intracellular domain. This intracellular domain is nothing but the T cell receptor activation kit. Now, the first generation CAR-T can identify the tumor associated antigen, but it cannot give a tumoricidal response because the intracellular domain is weak. So this does not have an anti-tumor properties. All the approvals of FDA, which have come up till now in leukemia, lymphoma, and multiple myeloma, are the second generation CARs. Because the first generation CAR couldn't give a tumoricidal effect, the intracellular domain was strengthened with addition of CD28, which is a co-stimulatory molecule, so that the T cell response increases. And this is seen to have a better response. And all FDA approvals, as I told, are at present for second generation. The problem is now when you look at tumor microenvironments in which there might be resistance for CAR-T, that may be because of variable antigen tumor heterogeneity, which would be the tumor microenvironment is not conductive for immune response, or there are immune suppressive cells which are present. In such situations, you want to have a more higher T cell response which comes. And in the third generation CAR, again another co-stimulatory domain is added. So its tumoricidal properties are higher than the second generation. The fourth generation CAR is also known as TRUC, that is T cell mediated release, which leads to a cytokine release, which actually kills the cells. Now, why does TRUC can do a cytokine release? Because it's a cytokine inducer. So this is a modification of the second generation where the cytokine inducer is put inside the intracellular domain, and which leads to a lot amount of cytokine release. So even if there's an immunosuppressive environment, Even if the cytokines are less, this truck car can overcome these features. So it said that the truck car could be the one which could overcome these resistance patterns which are commonly seen in solid tumors. The fifth generation car has an interleukin 2R beta gene. This leads to activation of JAK-STAT pathway, which again leads to a triplified amplification of the T cell receptor units. So the fourth generation and the fifth generation cars have high tumoricidal activities, but they also are associated with high amounts of cytokine release syndrome. Now, these are the issues in solid tumors. Today we are talking about solid tumors. A, there can be loss of antigen. So if the tumor-associated antigen is lost, the CAR-T cannot act. There can be a T cell exhaustion. There can be intrinsic resistance to CAR-T. Now, why would there be an intrinsic resistance to CAR-T? One of the main ways by which the CAR-T kills the cell is by activation of interferon gamma pathways. Now, if this interferon gamma pathways are not well established inside the tumor cells, it would be intrinsically resistant to CAR-T. Now, sometimes you may have the tumor-associated antigen to be common with normal cells. In such tumors, there will be an off-tumor toxicities in which a lot amount of the normal cells could get killed. Sometimes you may have a tumor microenvironment which is anti-inflammatory and immunosuppressive. Now, this is quite common in solid tumors, and this is where the truck, the fourth generation car, can come into play. Sometimes you may have a feature where there is not enough T cell trafficking or the T cells have not infiltrated the tumors. And again, in such situation, the CAR-T is less likely to be effective. Now, to overcome these CAR-Ts, the fourth generation and fifth generation CARs have taken different methods. What are these? One, in such times where there is no infiltration, you could have CAR-Ts which also have a component which inhibits the fibrinogens. You would have components which can inhibit the hyaluronidase. You can actually activate interferons, and I would show you some of the results in genitourinary cancer which are achieved by this. Now, there's another classification of CAR-Ts. Whatever CAR-Ts which I've talked about up till now and which are received are actually auto CARs, in which it is the patient's own T cells which have been genetically modified and given back to the patient. The problem is it takes around 20 days to make these antibodies. So, though it is individualized for each patient, it is access is limited. You cannot manufacture and keep these cards. Each time you have to manufacture for each individual patients. Now, allo cards are made largely can be made from alpha beta T cells, but can be made from gamma delta T cells also. The property of gamma delta allo CAR T cells is these are off the shelf cards. So these are readily available. These are made from normal humans. So the accessibility can increase, the manufacturing can increase, and the patient does not have to wait for 20 to 30 days. And many of these allo cards are actually MHC or HLA and HLA independent. So they don't even have, especially for gamma delta allo cards, they don't even have the issue of the graft versus host disease. And in solid tumors, in the whatever literature I understand, these might be the future. Let's look what is the role of prostate cancer. Now, prostate cancer is a perfect model for CAR T therapy. Why? It's a non-essential organ. It has several tumor-associated antigens, and which I have listed there. Slowly progressive, so gives the chance for immunotherapy to act. And there are many antigens which are actually have restricted expression or no expression with other normal tissues. A lot of these like PSMA, PCA, PAP have been tried, and these is in progress. But we have data from phase 1 trial for PSMA targeting done by tumor growth factor beta insensitive armed CAR T. Now, this is a unique CAR T. It optimally engineered PSMA CAR along with a tumor growth factor beta RDL. And this was used to neutralize the tumor microenvironment of the prostate, which is immunosuppressive. We got very good results with this in the phase one, in which nearly 40% of the patients had stable disease. These patients had progressed across multiple lines of therapy and with quite satisfactory median survivals. Understand these are elderly patients, a lot more comorbidities, and they had received a lot numbers of previous therapies. These results prove that in future you may see PSMA targeting, especially done with tumor growth factor beta in such situations. Let's look at the results in CAR-T and RCC. Think about it. Now, CD70 was identified as a promising target for CAR-T. And when you look at its expression with 1% or more to be considered as positive, in clear cell RCC, it's expressed in 98%. In papillary RCC, 32%. In chromophore, the number is 0. In collecting duct, it is around 11%. And in sarcomatoid, it's around 46%. So, a huge amount of clear cell RCC have this. Interestingly, we have had a phase one trial called Cobalt, in which an allogenic CAR was a CRISPR edited CS9 gene edited CAR T against CD70 was. The disease control rate was nearly 70%. Only 50% had CRS. Interestingly, there was no graft versus host disease, so an alpha beta curve. And this was achieved by mitigation of the beta 2 microglobulin knockout, and which actually proved that if you do the beta 2 microglobulin knockout, this might help to give CAR T without doing HLA matching. And this was a remarkable step achieved. Also, the beta 2 knockout also suggested that the natural key cell rejections for CAR T is minimal. How is this important? This allows for repeated dosings of the CAR Ts. Allo CAR Ts at off shelf, you could do actually repeated dosing. Only one problem, interesting results. There were some CR and long-term CRs also in the study. Interesting result because it's a CRISPR edited T cell product. It can cause chromosomal abnormalities. And hence, in these patients, you need to watch out if any future chromosomal abnormalities could appear. But another thing which shows that the promise of CAR Ts in RCC. Now, urinary bladder, we don't have updated results which have come yet. There are multiple trials going about. So if anything update comes, I will brief you in the next year's GU update. What about stem cell transplant? Now understand, in solid tumors, tumor is one of the setting where stem cell transplant has been established since 1986. ECOG phase 2 study showed that 1/4 of the patients can be cured. But there have been two studies which actually had negative results. In one study, stem cell transplant after 3 cycles of VIP was compared against the standard VIP 4 cycles. It showed a higher amount of event-free survival for the stem cells, but this was not statistically significant. Interesting thing was the randomization was done upfront. So the patients who underwent stem cell transplants were only 80%. So 20% of the patients never underwent the allocated treatment. Now, many theorists would point out to this as one of the reasons why this study came out to be negative. The study was underpowered to detect this difference. Interestingly, the North Americans believe that a single transplant is not the way in germ cell tumor, and you need to do tandem transplant. And how many tandems? Not one, not two, but 3 tandem transplants. It has shown to have a trend towards positive results. But this study by Lodge et al. Had to be stopped because of excess death. Yeah, and a TRM which was seen of 14%. But it's not the 14% TRM, you could see that there was near a 10% increment in survival at 5 years. But things have changed over the years. The supportive cares have improved. Facilities to do transplant have improved, and you could see from 1919 to 2015 steadily in the CPMTR data, the out improved. Interestingly, the CPMTR data also shows that patients who undergo 2+ transplant in germ cell tumor do better than single transplant. data also suggests that patients who are selected on the various criteria, they do better. Interestingly, if you look at this data, you could see that the transplant-related mortalities have come down drastically, and even the transplant-related relapse have improved. The PFS has improved, and the OS has improved as eras have gone by, suggesting that in today's era, transplant in germ cell tumor in an experienced hand remains safe and can improve outcomes. Now, what are we doing in India? In India, we have just gotten uh, expedite, you could say that the first level approvals for doing a phase 2 study of gamma delta T cells and CAR T cells in refractory solid tumors and lymphomas. And this study would start recruiting by July. And anyone if want to refer patient can just pin me the patient. We have already started screening for the study, and there are two cohorts of urinary malignancies, RCC and bladder cancer in this. There are overall 10 cohorts where we are trying to see in which cohort the gamma delta T cells can in solid tumors could have a role. So to conclude, I have overshooted my time. CAR T is showing promising role in prostate and RCC. So watch out for this phase. You may see good phase 2 data in this year and probably phase 3 data in the coming years. Stem cell transplant needs to be revisited, needs to be considered at second relapse, especially in a fit patient with germ cell tumor. Thank you for your patient listening.